Hello.
Hello.
Hi.
Hi.
Mhm.
Hi everyone. It looks like
Hello.
the screen sharing is disabled, so I'm just trying to see if Tasha or Mary can fix it.
Hmm.
Hi, Tasha. Thanks for joining. Should we try to have Ruth and Patricia share their screen?
Mhm. Or Maria and Patricia. Maria, I think.
Oh,
Yeah,
sorry.
I
That's
can
right.
try to share my screen. I think it should work. What happened? What can you see?
Okay, we can see your slides.
Your slides.
Yeah.
In
Is it okay now?
yes, now it's full screen.
Yep.
Okay, that's great then. I guess everything's working.
Mhm. Patricia, do you want to try as well quickly?
Yes, let's give it a shot. Um, okay.
Yep, that's
Oh, stop share. Just
Mhm.
looking for the button to stop.
that's good as well. So okay, great.
So what can you, sorry, can
We
you
can
see
s- we can see the slide, but not presenter mode, so we can see also on the side the.
Yeah, previously it just went into full screen mode for a second and then came back out again when you did play from start, I think.
is this
So
working?
This is good,
Yep.
yeah.
Yep. Yep.
Mhm.
Okay. Okay, thank you.
Like there's still people logging in, so maybe we'll give it like another 2 or 3 minutes, and the moderators can take it away.
Thank you to everyone who's joining us. We're going to give our attendees a minute more to join before we kick off. Okay, hello and welcome. Good morning, afternoon, evening, etc. to all of our attendees. And thank you so much for joining us today for this joint WFPI ISMRM webinar on developing and implementing artificial intelligence in pediatric MRI. We're delighted to have two outstanding speakers today. So it's my pleasure to introduce our first speaker, Maria Dupre, who's a senior lecturer in medical imaging at King's College London. Dr. Dupre, please go ahead.
Thank you so much for inviting me and giving me opportunity to speak at this webinar. So today I would like to talk about segmentation in fetuses, neonates, and infants, and particular challenges that we've got in these populations. Just a second, because, okay, it's working now. So I kind of assume that I'm talking to people that are more applied, no experts in deep learning. So I'll be talking very much from the applied point of view. So I start by introducing deep learning segmentation, just giving the key concept of what we actually doing when we training and using the networks. And then I will talk about challenges like domain shifts, segmenting small structures in low resolution images, having missing or partial labels, and then variability due to development and abnormalities. You probably recognize all these problems already from other areas. So I will start with a more historical thing, just to introduce how we used to do segmentation before deep learning came and artificial intelligence came, even though this is a clustering, which is also a machine learning algorithm. So by pure definition, we could say it's not really so different. It's still machine learning. But what we were doing, specifically in brain segmentation, because brain is taking always a lot of space, is that we would look at the intensities in the image. And this is kind of normalized image histogram, and we try to fit Gaussian distributions to the histogram to find where we have the individual tissues. So you can see three different peaks in this histogram, and they correspond to gray matter, white matter, and CSF. And by fitting these Gaussians, we can work out how to find the individual tissues in the image. Of course, three tissues are not enough for us, and especially if we look at babies and children, their brain grows a lot. So, and we also might be interested in other structures, not just the three tissues. So what we also traditionally used is prior information about where the individual structures should be positioned. And this was in form of a probabilistic atlas or labeled atlas that can be aligned to the images. And then this information is used in addition to the intensity. So this is kind of old school strategy. And maybe many of you know Developing Human Connectome project, and the segmentation of neonatal brain is done by DROIM, which is based on this type of strategy. So we have 20 segmented atlases that have structures of the brain segmented in them. So not tissues, is not separated gray matter, white matter, CSF, but regions of the brain. All these are registered to the image, and from that we can use label fusion, label propagation.
Pediatric AI and pediatric MR. So which have the
have the attendee please mute?
Okay, so we have a label propagation and fusion, and that way we can get these structures in the new subject. So it's all automated, and then we can use EM segmentation, so similar to what I was showing you, to get the tissues. And when we combine that, we get 86 brain regions that you can find in DHCP. So this is very simplified way of putting it, but this is the core concept, how it was done. Now, when we use deep learning, situation changes, because what we want this time is to have a neural network, and you give your image to the neural network, and neural network returns the segmentation. So that's what we want to do once we have the neural network. But of course, first we need to train this neural network, teach it how to give us the segmentation. And for that, we need many examples of input and output. So that's what's different. We don't do modeling, but instead we're showing the network lots of examples, and we want it to learn from the examples. And the idea is that basically at the beginning, the network doesn't know what to do. So we give it input, it produces some output, and we then compare this output to our manual segmentations. And then we update the weights of the network so that it outputs something closer to that segmentation. And that is called training. So it's very convenient because there is nothing really complicated to do. We just train it if we have enough data. So it's easy to train and use. You can just download a ready-made network such as UNet and train it on your data if you have a nice curated data set. And here I want to show you some kind of networks that are accepted as a very common benchmark. So one would be no new unit, which is a self-configuring unit, which is nice to grab, and it's a accepted benchmark because it will automatically adapt to your data. And then one that we prefer actually is attention unit from Monai. So that's another thing that is really accessible, and you don't need to understand a lot about deep learning to be able to train with these methods. So the reason why we like attention unit, because we realized that it can segment small structures that in a very low resolution images. For example, these are cardiac vessels, and you see that these small vessels were segmented much better than attention unit than by UNet. So we don't generally tend to use just original UNet, but attention unit. But that's kind of important in pediatrics when the resolution is not high enough compared to the structures that we want to segment. All right, so once the network is trained, it's easy to apply to new data. Prediction is really fast. It takes milliseconds. For example, drawing pipeline takes several hours to run for individual subjects, so that's very time consuming. So trained networks are amazing because they just produce outputs very fast. And they can be very accurate and flexible. You can learn any segmentation protocols. You don't need to have like intensities that are uniform, or so it's amazing, and it solves so many of our problems. But of course, it couldn't be without challenges. There are problems as well. So first of all, training requires many manual segmentation, and this is a key issue because we don't tend to have lots of training data in pediatrics. Data is scarce. Then we have domain shift. So this is common to both pediatrics and other areas. So the network will not work if data is different. For example, if it's trained on T2 weighted, it won't work on T1 weighted, and even more subtle changes may stop it from working. Now, also small sizes of structures compared to resolution are an issue, as I showed you before. And we have lots of anatomical variability due to development and anomalies as well. So we have small data set and large variability. So this is really a sticking issue in pediatrics, that we don't have a UK biobank with tens of thousands of images. So we need to deal with small data set with large variability, and that's what makes it actually quite difficult. So I want to share our experiences, how we dealt with these different challenges, and I will start with domain shift. So in this case by domain shift, I mean having data from different scanners where the MRI sequence is a little bit different. So developing human connectome project, the neonatal brain data set is quite known, and we have draw EM labels because they were produced by using these minimal processing pipelines. But we would like to apply it to another data set. And the example that I have here, it's E prime. It's a private data set that we've got of very preterm babies scanned at term. And basically, what we would like to do is to take our DrawEM segmentation from DHCP and train the UNet, let's say, on DHCP data. And then at inference, we would like to predict on E prime and see whether this could make our workflow easier, because then we just need to use the network and we can segment all the E prime data as well, and maybe some other databases. But it turns out that's not so simple. So I want to show you what's the caveat here. So here is the cortical thickness extracted from DHCP and E prime. And E prime is purely preterm babies and DHCP is term and preterm. So what we did here, we chose age match subset. So we have an equal number of DHCP and E prime subjects, and they were matched for postmenstrual age, gestational age at birth, and gender, to make sure that the trends we should see should be the same. And you can see when you plot these curves of cortical thickness, they are not really the same. So this is a big problem, because E prime has thicker cortex than DHCP, and obviously that's not a real thing. That's the artifact of the method, because the contrast and resolution is a little bit different. And you see that it's a problem already with classical methods. It doesn't give us the same result, but it's even worse with the deep learning. If we train on DHCP and then we predict on both DHCP and E prime, we get a very big difference in cortical thickness. And of course, then you cannot really do proper analysis when it looks like this, because the database that you use, the scanning protocol, has much larger impact than preterm birth. So this is a big problem. So one of the things that seem to help quite a lot is data augmentation. And this is really important to use in deep learning in general, but in pediatrics, it's even more important, because data augmentation helps us to regularize the networks, create by simulation more diverse data sets, and that way the training of the network is better. They are more generalizable and more constrained and behave better. So this is an example on adult brain MRI, and I put it here because that's the original paper, and these methods are now implemented in MONAI, so you can use them directly if you work in MONAI. So here we have the brain MRI and the segmentation. You can apply random deformations, and then you deform labels as well during training. You can change the contrast with simple thing like gamma correction. We find it very useful on MRI, especially if it's all T2-weighted images, just different, slightly different contrast. Gamma correction covers it pretty well. Random noise, random bias field. Of course, bias field is a huge problem in MRI, and differences in resolution can be simulated by just blurring the images, actually. So you can do all these different variation during training, and then your network sees much bigger variation of data, even though your training data set is small. And then we've done another thing that is called domain adaptation, and this is specifically if you want to use two domains and join exactly the DHCP and E prime, so it's not as generalizable, but still, if you have two databases you really want to join, it's useful. So we train another network that is called generator network to convert the contrast from DHCP to E prime alike. And the way we do that is that we get a discriminator where we actually teach this discriminator to predict whether the image is fake or real E prime. And we have something weird, which is called adversarial loss, that basically we want the network not to be able to do it. So we want generator to be so good at changing from DHCP type image to E prime time image that this discriminator will not be able to tell the difference. And once we do that, then the images should be very similar to each other. And after that, we train the UNet or another segmentation network based on drawing segmentation from just DHCP. So these are two different approaches that we investigated, and I'll show you some results now, whether it was effective. So these first two plots you already seen, these are the problematic one where cortical thickness is different. And if we just apply the augmentation, you see how nicely these cortical thicknesses come on top of each other. It's not perfect, but it was not statistically significant. So we get them much, much closer. And domain adaptation, the second approach did even a better job. Actually, they look almost identical. So we were able to solve this problem with this type of techniques. And here are some results. So what we wanted to do is to compare cortical thickness trajectory in term and preterm babies. And to harmonize the cortical thickness, we use both data augmentation and domain adaptation. So both these two approaches together. And here is how it worked. So if you look at term and preterm babies on DHCP only, this is the pattern that we see. I can't tell you why, but it seems around time of birth, cortical thickness is about the same. But somehow preterm babies then have the cortical thickness increasing faster than term babies at this time point. But if we don't harmonize, so if we just use network train only on DHCP, you see that this pattern changes a bit. We see much bigger difference, but of course it's not because the cortex is so much thicker. It's because E prime database is the preterm babies only, and there is this domain shift that we have thicker cortex because of the contrast of the image. And once we do our data harmonization through augmentation and domain adaptation, we get the same pattern as if we use DHCP only. So this actually worked. So this was one of our first attempt at data harmonization, and we were successful. So we were really encouraged that just doing data augmentation properly actually does solve 95% of the problems that we've got. So that's really encouraging. So it's being very careful and simulating these MRI differences properly is really the right approach. Now, domain shift can be even larger. So here we can see difference between neonate and 6 months old. So we had a database of 6 months old, and we were wondering whether we could use neonatal segmentations to segment brain in 6 months old. And of course, myelination is going on, so the contrast changes drastically. It inverts during the first year of life between white matter and gray matter. So this is a really, really hard task. And on top of that, there is also shape changes because the cortical folds will deepen. So this is very hard task. So we try to do like this kind of a domain adaptation. So here you can see if we train on DHCP, and then we predict on 6 months old, we get really bad segmentation. You see, like we completely lose white matter. And of course, it makes sense because the contrast is inverting. So we expect it not to work. So what we've done two types of augmentation. We use cycle gun to change the contrast between neonate and 6 months old, which is a bit newer strategy than the domain adaptation we did before. So this is our newer work. And also we use the voxel morph for image registration to try to match the shape, so to deepen the folds so that it looks more like 6 months old, and then we train the segmentation. And this was successful, even though it was not perfect, but we were encouraged that actually this strategy can work as well. At the end of the day, we gave up and we actually replace the cortex from I-beta segmentations because these were segmentations trained on actual manual labels from 6 months old, even though it was different protocol, but this worked much better. But I think if we only did that on T1 weighted, T2 weighted data, and I think using T1 and T2 contrast might have actually pushed our augmentation strategy to be working as well, but we somehow ran out of time. So again, I think this is quite tricky thing to do, but I think results are encouraging. It can actually work this way. So that's it for the brain and for the domain shifts. Now I want to talk about small structures, and here I have another application. So this is segmentation of fetal heart. So we started doing reconstruction, motion correction of fetal MRI the same way that's normally used for brain. We started doing it for the heart a few years back. And then once we reconstruct the fetal chest, we can segment the heart. And these are manual segmentations that are performed by our clinical fellows. And it's very nice for visualizing the anomalies of the vessels in the heart. But these manual segmentations are very time consuming. So we wanted to train a network to help the clinicians to actually get the segmentations automatically. But unfortunately, that turned out really difficult. This is what UNED did. Some of the small vessels just wouldn't get segmented at all. So that was very disappointing. So then we actually discovered that if we use attention unit, we are getting much better results. So this was more encouraging. It is still very hard to do properly, but with attention unit, we could do better. But then we had an idea, so whether the network will actually learn better if we segmented individual vessels. So we wanted to try that, but we didn't really have labels for individual vessels. We only had the binary labels, so just heart and vessels or background. So what we did, we created an atlas, and actually we created 4 different atlases for normal heart and for 3 types of anomalies. And a clinical fellow did these beautiful segmentations of different vessels in this atlas. And then we use label propagation, so to individual data sets. So this is just image registration, and then the labels are transferred to new images. And then we could train UNED with these propagated labels. So the labels are not perfect, but UNED can maybe correct these segmentations based on intensities. And you see they look much nicer because UNED actually sees the image and fixes some errors on the boundaries. But then the next question was, well, that's a shame that we are not really using these binary labels that our clinical fellows produced with so much effort and so many hours of segmentation. So then we decided to try to train a multitask network. So we would use the propagated multi-class atlas labels. So that's basically just created automatically with image registration and these manual ones. And we would put 2 losses. So one loss would be to make the predicted multi-class labels similar to the propagated labels. And the second one would be we join the multi-class label into a binary mask, and then we can also use manual labels. And this is for what happens. So what we found that with manual labels, we got the highest die scores, but this is when we compare with manual labels with the binary masks. And lowest die scores was with labels that were propagated by registration. And when we combined the 2 losses, we were somewhere in the middle, which is not like terribly encouraging. But when we investigated a little bit more precision and recall, we saw that there are actually some important differences that when we use propagated labels, we're actually having under-segmentation, and with manual labels, we have over-segmentation, and you can see it here that the individual vessels actually merge together. So overall, it's higher overlap, but it's not really accurate segmentation, and it's not as good clinically. So actually, our middle ground that doesn't have the highest die scores, but it has the best there's a balance between precision and recall, and it gives us most balanced segmentations, and the vessels are nicely separated. So we think that it's actually clinically more useful, even though the ice is a little lower. And then also we have lots of anomalies in this data set because these babies have congenital heart disease. So we thought, how do we deal with the anomaly? And so what we added was another thing, which was condition classifier to predict the diagnosis. And in this work, we just done the biggest diagnosis that we have, which is right aortic arch, double aortic arch, and the coarctation of aorta. And this conditional classifier can help because if we know the condition, it can segment better the double aortic arch, for example. So here you see the original network wouldn't segment this narrow arch, and that is basically it leaves out the anomaly. So this can be a problem. So with this condition classifier, it was able to actually segment this arch. So last thing I want to tell you is about variability during development. So again, it's a similar strategy, but this time we are back to the brain, but fetal brain. This is the work to segment transient layers in fetal brain. So the ones that you see here is ventricular zone, ganglionic eminence, and the subplate. But of course, we didn't have any labels. So what we did, we segmented these layers in the atlas, and we did it semi-automatically. And then what we did, we have a database of subjects, and we select the age-matched template, and we do label propagation. So we get a training data set for training attention unit, and then we get automated segmentation network. So this network is almost ready. We've been working on it for several years and perfecting it. So it will be eventually released and come with DHCP segmentations. And this way, by doing the segmentation in the atlas, we were able to deal with this variability. And actually here we didn't have any manual segmentation. We just corrected the semi-automated one in the atlas. So I'm not going to do any summary in just to stay with time. And I just want to thank, of course, to my group who were working really hard on this segmentation and all my funders. And thank you very much for your attention.
Thank you so much for that wonderful talk. I'd like to hand it over now to my co-moderator, who will introduce our next speaker.
Yes. So I guess we'll have questions to both talks at the end. So we'll just move on to the second talk now. It's a pleasure to introduce Patricia Johnson. She is an assistant professor in the Department of Radiology at the NYU Grossman School of Medicine, and she'll be talking to us about how deep learning may speed up image acquisition. So thank you, Patricia.
Thank you, Ruth. Can you guys hear me and see the slides?
Yes.
Okay. Thank you, Ruth. Thank you for inviting me to speak today. It's really exciting to be here. So I'll focus on how deep learning reconstruction enables faster MRI acquisition. So this spans early research work through methods that are now clinically deployed. And towards the end, I'll talk a little bit about what the next generation of deep learning reconstruction tools will look like. So I have no financial disclosures. Sorry. So my actual disclosure is that I don't do pediatric imaging, but what I do work on is deep learning reconstruction. And these methods are grounded in physics and optimization, not anatomy. So this makes them very broadly applicable to pediatric MRI, where scan time and motion are major issues. So I've personally worked on bringing DL reconstruction to musculoskeletal imaging and both neuro and body imaging. And this also shows how diversely applicable these tools are. And at NYU, we're now running DL reconstruction for all of the protocols seen here, and probably at this point a lot more now as well. So we all know that MRI is relatively slow imaging modality, and there are several reasons for that. So this includes relaxation times, SAR limits, gradient performance, and sequential case-based acquisition with the requirement for Nyquist sampling. And it's really this last one that we'll focus on today. So we know that MRI is slow because reconstructing aliasing-free images requires dense case-based sampling. So that means sequential phase encode lines and long scan times. And if we undersample without doing anything smart, we get structured aliasing. So the core problem in fast MRI is how to undersample case-based and still recover a clean image. And obviously this is not new. So we've been using parallel imaging for decades and compressed sensing, and conceptually all of these methods are solving the same reconstruction problem. Parallel imaging methods like RAP and SENSE use coil sensitivity differences to fill in missing case space, but they break down at higher accelerations. And then iterative regularized reconstruction reframes MRI as an ill-posed inverse problem, and it stabilizes it with a prior. So in compressed sensing, that prior is hand designed. It's typically a sparsity constraint, like the wavelet compression that I've shown in the figure here. And then with deep learning reconstruction, it fits into the exact same framework, but instead of assuming what the image looked like, instead of assuming the sparsity constraint, we learn the regularizer directly from data using a convolutional neural network. So the physics stays the same. What changes is how powerful that prior is. So at the core, MRI reconstruction is a minimization problem, and I've shown the optimization function here. And what we want is an image that agrees with the measured case-based data. So that's that first term in the equation, the data consistency term, while also obeying some prior about what the image looks like, and that's the regularization term. So in compressed sensing, again, that prior is hand designed, typically sparsity. And then in deep learning reconstruction, we're learning it directly from the data. Everything else in this equation stays exactly the same. So rather than solving this optimization iteratively at test time, we learn the optimization itself. So we unroll a fixed number of gradient descent steps, typically for most of these unrolled networks on the order of about 10 gradient descent steps. And in each step, we alternate between enforcing data consistency and applying a convolutional neural network that removes artifacts. So the network learns how many steps to take and how aggressively to remove artifacts at each step. This is what people refer to as an unrolled or model-based deep learning network. So the training is fully supervised, where the input is undersampled case space and the initial image estimate is a zero-filled image. So we start with the undersampled data, we run it through the reconstruction model, and then we compare it to a fully sampled reference image. And then the reconstruction error drives learning through backpropagation, and we update all of the model parameters in that convolutional neural network end to end. And then once this is all trained, this entire iterative process collapses into a fast deterministic reconstruction at inference time. Okay. So major differences between classical and deep learning reconstruction. On classical reconstruction, we use explicit priors like sparsity. And then in deep learning reconstruction, again, we learn these implicit priors from training data. In compressed sensing, it required manual tuning regularization problems, whereas with deep learning reconstruction, we're learning these parameters end to end. And the key difference is that at inference time, reconstruction is very quick with deep learning reconstruction, as opposed to classical iterative reconstruction like compressed sensing, where it was computationally intensive. Now, a good resource for developing deep learning reconstruction tools is the FastMRI repository. And this is a large repository that we've released at NYU with large amounts of fully sampled case-based data. So the initial release focused on knee and brain. So there's 1,400 raw data sets for knee with two contrasts, the proton density and the proton density FATSAT. And then we also have the brain data set, which is 7,000 volumes of case-based data with several different contrasts for the neuroimaging data set. So this was the initial release, and we've since expanded it to include some different types of sequences. So we've included the diffusion-weighted imaging for prostate, and then some grasp sequences for breast. And we are still always looking to expand this. So if there are any specific data sets that would be useful to this pediatric imaging community, please do let us know. We're always looking to expand. Okay, so now I'm going to go over some exciting examples of deep learning reconstruction. Okay, so this paper is one of the earliest studies that really demonstrated clinical value. This is one of my favorites it's from a few years ago now. And importantly for this audience, it focuses on pediatric abdominal imaging. Again, where long scan times and motion and the need for sedation are major barriers. So using a variational network with variable density, single shot, a fast spin echo, they achieved over a threefold acceleration. And then compared to parallel imaging plus compressed sensing, the deep learning reconstruction showed improved perceived SNR, sharpness, and overall image quality. So this example makes the clinical relevance really tangible. So this is a non-contrast coronal image in a 15-year-old girl comparing a conventional reconstruction to the variational network. And despite the higher acceleration, the DL reconstruction shows visibly reduced noise, improved sharpness, particularly along these organ boundaries. Okay. And this is a more recent study. This is from from Florian Knoll's group in Erlangen. This tackles a really challenging problem in MRI, cardiac cine imaging. This is extremely sensitive to motion, and it traditionally requires long breath holds. So that's challenging in adults, and even more so, obviously, in pediatric patients. So here the authors are again using a variational network called CineVN, and it enables high spatial and temporal resolution cine imaging. So they're achieving acceleration factors around a factor of 16 with high in-plane resolution and very high temporal resolution. So this comparison shows why this really matters clinically. So across both the multi-shot and the real-time acquisition, so the multi-shot on the top row and the real-time on the bottom row, the CineVN on the left is compared to two compressed sensing reconstructions. So this is the vendor CS in the middle and the total variation-based compressed sensing on the right. And then we can see the CineVN better preserves the myocardial boundaries and reduces motion-related artifacts, particularly in the real-time example. So for pediatric imaging, this would be critical. Real-time cine without breath holds opens the door to functional cardiac assessments in patients who can't cooperate with conventional protocols. And the key result is that CineVN didn't just improve image quality metrics, it also improved functional accuracy. So measures like ventricular function and myocardial strain were actually more accurate with the CineVN than with the compressed sensing methods. Okay. So over the next few slides, I'll talk about some of the work that we did in clinical validation of accelerated protocols with the variational network. And these studies were focused mostly on knee imaging. So we know early on when we were developing these tools that we were getting, high structural similarity index and qualitatively good images. But the next step was obviously to consider, how do these images compare to the clinical standard and are the protocols interchangeable? So for example, is this twofold accelerated knee, which is the clinical standard, clinically interchangeable to this VN reconstructed that's acquired 2 times faster? So how we did this, we recruited 170 subjects that were referred for clinical knee MRI. So they underwent both the conventional, so twofold accelerated with grappa, and prospectively accelerated for fourfold with our VN reconstruction. So they did both exams. And for each exam, they were reviewed by 6 musculoskeletal radiologists, where they were evaluated for the likelihood of a tear or abnormality. From definitely absent to definitely present. And we looked at meniscal tears, ACL tears, MCL tears, and other chondral abnormalities. And they also evaluated the image quality for presence of blurring and artifacts and perceived SNR and overall image quality. So the findings were that these protocols were diagnostically changeable. So the radiologists were making the same diagnoses on average in the clinical protocol, the conventional protocol, and the deep learning protocol. And an interesting finding was actually that the overall image quality scores were better for the DL Recon. And we think there's, two main reasons for that. And one of these reasons is illustrated on the right. There's less motion generally on average in the shorter protocols. So in this example, we can see the pretty substantial motion artifacts in the conventional protocol. And there's definitely still some artifact in the deep learning protocol as well, but it is less severe. So this is a good illustration of kind of less motion overall in the accelerated protocols. And additionally, these deep learning reconstruction methods have kind of an inherent denoising property. So the images do appear less noisy as well. And here's an example of the conventional knee on the top and the deep learning reconstruction on the bottom. This is an example with an ACL tear, a subchondral fracture, and meniscal fraying that are all visible in both the conventional and accelerated protocols. So far I've focused on academic and investigator-led validation studies. And the important next step is that this is no longer just kind of a research story. So every major MRI vendor now has an FDA-approved deep learning reconstruction product deployed for faster imaging. So what's been critical over the last 2 years or so is independent validation of these tools. And this study is a good example of that type of validation. So they evaluated a commercial deep learning reconstruction for full body diffusion weighted imaging for B900. And they showed that the DLR produced cleaner maximum intensity projections while also significantly reducing acquisition time. And this is particularly relevant for oncology imaging. And this is an interesting example because it actually focuses on DWI, and a lot of the early development and validation work was for TSE sequences, and DWI came a little bit later. So this study is another strong example of a commercial deep learning reconstruction product. So here they evaluated a sub 5-minute knee protocol, and it has an effective acceleration of 6-fold acceleration. So this actually comes from twofold from the simultaneous multi-slice and then parallel imaging factor of 3. So they had 7 radiologists and 124 patients with arthroscopy as ground truth. And they're showing high sensitivity and specificity for internal derangement injuries and non-inferiority for the accelerated scan times versus the conventional. So one more example, I wanted to show all of the major vendor products. So this final example comes from lumbar spine imaging, and it reinforces that same message. They evaluated this commercial tool in accelerated lumbar spine and achieved about 30% reduction in scan time. And the accelerated protocol shows comparable image quality and non-diagnostic performance, and non-inferior diagnostic performance. So taken together with the prior examples, it shows that the vendor implemented DL reconstruction can reduce scan time across diverse clinical applications. And so far, what I've focused on is the unrolled model-based deep learning methods, which have been the dominant approach in clinical practice. And they work really well, and they're already deployed, so you can use them clinically. But as these methods mature, we're kind of thinking about what the next generation of these tools look like. So the next section, I'll talk about where deep learning reconstruction work is heading and why that matters for generalization and flexibility. So in the unrolled models, like the variational network, the learned regularizer is tightly coupled to the forward operator. So that's the sampling pattern, the trajectory, and the coil configuration used during training. So that tight coupling in some ways makes it really powerful, but it also means that these reconstruction algorithms may not generalize perfectly to unseen sampling patterns or acquisition schemes. And in practice, this isn't a problem for standardized clinical protocols. But as we move towards more flexible and adaptive acquisitions, we want to look for more generalizable reconstruction tools. So one alternative is class of techniques that we broadly refer to as modular deep learning reconstruction. And here we learn the image prior independently using typically generative models that are trained purely on images. So during reconstruction, the solution is then required to rely on this manifold of images that the generator can produce. So this decouples the prior from the acquisition physics. So this can improve generalizability, and it allows training even when raw case-based data isn't available. The trade-off here is computational cost. So these methods are typically slower at inference, but they do represent an important direction for future MRI reconstructions, particularly as the compute on our scanners gets better and better. So the inference time penalty becomes less relevant. So I'll show a particular example of these types of modular DL reconstruction, and diffusion models have become really popular in this space. So this is a score-based diffusion model. So we learn what's called the score function. And the score function just means it's the gradient of the log image probability distribution. So intuitively, the score function tells you how to nudge a noisy image to make it look more realistic. So during training, the model sees the images corrupted by different noise levels and then learns how to point them back toward the high probability clean imaging manifold. So it learns the structure of realistic MRI images and then constrains the reconstruction to kind of lie in this space. So at test time, this learned score is plugged into an iterative reconstruction algorithm that also enforces data consistency. So the physics doesn't change here, it's just how we learn the prior. So each update step balances two things, matching the measured case base, so the data consistency term, and the forward model. So moving the image towards something that looks anatomically realistic according to that diffusion prior. So again, the physics doesn't change here. We're just changing kind of how we train the prior that we're using in the iterative reconstruction. So these methods are powerful because that prior is learned independently of the acquisition, so it makes them more generalizable. But again, the trade-off here is that inference is currently slower than unrolled networks. So conceptually, these models differ in how the prior is learned and used. With model-based unrolled networks, the prior is learned as part of the reconstruction by unrolling an optimization algorithm. They're fast at inference and highly effective. They're well suited for clinical protocols, for standardized protocols, which is why they dominate current FDA-approved products. But the modular generative priors, on the other hand, learn the image prior independently from high-quality images. And that makes them more flexible and potentially more generalizable, especially when raw case space is not available for a certain application. And so examples of the model-based, we talked about VARNet a lot. Modal is another example. And for the examples for the modular generative priors, we talked about score-based. This is a diffusion model, and there's also generative adversarial networks in that space as well. Okay. So I do want to end with a note of caution. So commercial deep learning reconstruction tools have undergone extensive validation, and in routine practice are generally reliable for moderate acceleration factors. So roughly 3 to 4-fold for most 2D acquisitions, and somewhat higher for 3D sequences or when it's combined with simultaneously multi-slice. But deep learning reconstruction is not magic. And if you don't acquire enough data, the reconstruction necessarily leans heavily on the learned prior. And you can see it in this example, a very obvious pathology in this brain MRI that really starts to get kind of removed by 32-fold acceleration. And at that acceleration factor, you just acquire so little data that the reconstruction relies very heavily on this prior, and you start to kind of reconstruct an average brain. So it's really relying on that population prior. I mean, this is not a new problem. It's the same kind of fundamental trade-off we've always had in MRI reconstruction priors. And the takeaway here is to be thoughtful and reasonable with acceleration factors, and use deep learning reconstruction to improve efficiency and robustness, but it's not magic. It's not going to replace the physics. Okay. So in summary, we know that MRI is slow, and over the past few years, we've developed deep learning tools to enable faster scans by reconstructing images from undersampled data. The model-based methods kind of dominated the landscape for a long time, and those are commercialized and being used clinically. Modular generative models offer flexible priors, but as of right now, slower inference, and they haven't made so many inroads yet into clinical practice. As far as I know, there are no FDA-approved products in this space, although we will be testing one for a vendor in the coming months. Deep learning continues to improve speed and image quality of MRI. So these folks were all heavily involved in this work. Some of them aren't at NYU anymore, but this is the team. Thank you.
Thank you very much, Patricia, and also to Maria earlier for these great talks. So now we have some time for questions. So please, if anybody has a question, you can either unmute yourself and just go ahead or write something in the chat. And maybe while we're waiting just to get things started, I had a question, or a couple of questions for Patricia, actually. So on a practical level, so when people have these choices of sort of like weak or strong DL strength on their scanners, how would you recommend that they try to sort of optimize that? What should they look for? Obviously not these very high accelerations like you mentioned at the end, but if you're trying to optimize your protocols, what sort of things should people look for to get the DL strength sort of optimal for a certain protocol?
Yeah, and that's a tricky question. So our radiologists spent a lot of time doing this for our different protocols, and I think that they tend to lean towards, this is just kind of in our practice, they tend to lean towards the stronger DL recon options, and stronger DL recon options at kind of more moderate acceleration factors generally. I mean, it has, and it does differ. So between the body and the MSK, I know that they have different preferences for how kind of smooth these images look. So the radiologist kind of from those sections really decide kind of what those protocols look like. I don't really have a better answer. It's really just kind of what the radiologists like in those sections. Sorry.
No, and in all the experiences sort of comparing these to the standard product recons, have you ever come across any unusual cases where you feel like the DL really didn't work well, or some pathology was masked even without a very high acceleration factor, or have you not really observed that so far?
So when we were investigating some of these in the faster MRI challenges, for example, there were definitely cases where pathology was not visible in the DL recons, but that was always at like 8-fold acceleration. So I would say that when we're kind of in the regime where we're just kind of pushing the acceleration factors just slightly higher than we would have with compressed sensing and parallel imaging, we're just not seeing that.
Mm-hmm. Oh, great. Does anyone else have any questions?
Can I ask a question?
Yes, please go ahead.
Yeah, very nice talk, Patricia. Yeah, I also have a question about this deep learning recon. So, could you also comment on the untrained model, um, like how you, I mean, what's the role that this method may actually play when it comes to accelerated recon? It seems to me the on-road network based recon, that's the end-to-end training, right? So you basically have to train a model, and this is also applied to this modular generative model that
Yes.
you described. So all these you have to train a model and learn about the data. So it seems to me there's also other method they use the untrained model, such as the implicit neural representation. So could you also comment on how that method could help us do better job of image reconstruction? Thank you.
Yeah. So the implicit neural representation work, I think, so a lot of the untrained or zero shot methods in this space are kind of generalizations of Rocky. So Rocky was one of the really early machine learning methods for a machine learning extension of grappa. And I think that, those types of techniques can be really powerful when you're in applications where you just don't have a lot of training data. And when you do have a lot of training data, it's kind of hard to beat these end-to-end techniques. But obviously that's not realistic for every application. So methods like Rucky or implicit neural networks that are more zero shot and you're not training models on large data sets can be really valuable when those data sets just don't exist. But it is hard, I think, for those methods to compete with these large models that are trained on thousands and thousands of cases.
Okay, cool. So another actually idea of AI-based recon just popped in mind is the so-called self-supervised. So it seems to be that kind of a method actually has value when you don't have fully sample case base or a ground truth. Could you also comment on how that method could actually help AI-based reconstruction, especially when it comes to pediatric neuroimaging? Thank you.
Yes, absolutely. And you're absolutely right. There were definitely some things that I didn't cover in this talk. And self-supervised, so SSDU, self-supervised learning, was one of the methods developed a couple of years ago. And this works well when you don't have fully sampled case space to train these models. What we've also learned is that you don't necessarily need fully sampled case space to train the end-to-end models like the unruled network, and you can have your target just be a grappa reconstruction, for example. So self-supervised, or sorry, the semi-supervised methods like SSDU can be really valuable when you, again, like you said, we don't have fully sampled case base. But I think in a lot of applications, there's also alternatives and you can still use the supervised methods. You just don't have a fully sampled ground truth. And it still works fairly well when you have, for example, like a grappa twofold accelerated image for your target. And that works really well in practice because yes, like fast MRI has tons of fully sampled case-based data to train these models, but most of our clinical protocols we've been running for years are twofold undersampled with reconstructed with parallel imaging, and you can still use those as ground truth for training these models.
Okay, thank you very much.
Okay, thank you. So are there any further questions for Patricia or for Maria?
I've maybe in the last minute, I have a question for Patricia, which is a little bit of a philosophical question that keeps me up at night, which is I feel like, we do a lot of work on these all sorts of great machine learning reconstructions, and we're under the assumption that the manifold that we're learning or representing is, related to the MRI physics, and certainly it is, especially when we try to impose certain constraints. But there's also a component of that manifold that is, as you showed in your last example, that's driven by the priors, right? Particularly in a lot of these kind of end-to-end formulations. And when it comes to the pediatric setting, where we often live in the tails of the distributions, it's very hard to know, whether the manifold that you're learning, regardless of what technique you're doing, how much of that manifold really represents these are just tricks you're learning about MRI acquisition that are always true, and how much of these have this embedded information about priors or about the image. And even if you go to things that are self-supervised or implicit, there's often total variation assumptions or other types of regularizations that put in. And I think from the pediatric perspective, it becomes very hard to understand how do we push things really far when we kind of always live in one sort of data constrained environment, like Maria showed. And two, even when we have a lot of data, the representation of our pathology in that data may be very scarce just because it's so rare.
I really do share your concern with some of our priors maybe not being representative of pediatric populations and even just underrepresented populations. I think for some of these more physics-based models, it is a little bit less of a problem because what the model's really learning is, how it learns kind of the structure of aliasing artifacts and how to remove them from the images. So it's really less focused, I think, on the anatomy and the pathology. So some of these other methods where you're using generative priors and you're really forcing kind of the reconstruction to live on this manifold of this kind of population level manifold. I think those techniques, it is going to be a lot more crucial to make sure that those manifolds represent the population that you're dealing with. But I also think that you don't need, because you don't need deep learning, you don't need case-based data for all those applications. You can use all of the images that you have to kind of learn those priors for specific use cases. So pediatric imaging, for example. So I think it has to be done carefully, but it is an absolutely valid point that these priors we need to make sure that they are representative of the demographics that we're using them to reconstruct the images.
Thanks so much. Well, I think we're pretty much at time. I want to thank the speakers and both of our moderators, Dr. Barkovich and Tura, for helping out with this webinar. As Mary put in the chat, we will have part 2 of AI in pediatric MRI probably after the ISM MRM annual meeting sometime this summer. So keep an eye out for that. But thanks again to our moderators and our speakers.
Thank you.
Thank you.
Thanks, everybody.
Thank you, everyone.